after the surgery. These were the fields, but possible only in 17 because these were atrophic cases, and we had minimum 6 weeks follow-up to 24 months. We tried to establish and look at outcomes in terms of visual acuity, visual fields, and the disc edema resolution. And we had, finally, these were our results. We had 6 unilateral and 21 bilateral cases. Of the 6 unilateral with good vision, we operated on those with the poorer vision. Of the case with poorer vision, we had 1 child which had low vision in the left eye, so we operated in that eye. But we had 1 patient with no PL, so we operated 1 eye of that patient. Among the 21 bilateral, we had good vision. 6 eyes of 3 patients from 6'6" to 6'18", 6 eyes of 6 patients with 6'18" to 6'60". In case of the poor vision, we had 16 eyes of 11 patients with counting finger to 5 meters, but we had about 14 eyes with either hand movements, PL, and no PL. So what we found is if you operate in time with good vision, we were able to improve vision or maintain them, and visual fields also improved or stabilized. In those in which we operated in time just before of low vision alone, they did well, either improved or stabilized, but those in which there was no PL or just PL or hand movements did not improve at all. So what we tried to summarize is out of the 48 eyes, visions which were better than 6/60 all did well. Those with 6/60 less had ambulatory vision, but those with poor vision had no change. Which means of the 34 eyes, or the 71% with at least counting finger to begin with, maintained ambulatory vision, that means were successful in all cases, of which vision improved in 23% and stabilized in 48%. So basically, we showed that there was complete resolution on B scan by about 4 weeks. It starts within a week. Visual fields improved in all, and there was no vision-related complications. What we know is that ONSF does very well in cases, in early cases where you are able to pick up and the fields and vision is not affected. But we were able to show that even in cases of atrophic papilledema, it still works, and it can salvage vision in those with flat, pale discs. Ambulatory vision is possible if the vision is start to begin with is counting fingers, but no role if there is PL, and B-scan is a very good tool that we can use to detect these cases. Now, another role of B-scan, what I want to put through to you, especially prior to an optic nerve sheath fenestration. Now, this was a patient that reported to me on 30th October, which was a Saturday. You can see the vision is, there is significant pallor and disc edema. Central vision was fine, but if you look at it, there's significant elevation on OCT, the RNFL thickening, fields were completely affected, yes, including the macular field, which tells me, yes, I have to go in for optic nerve sheath fenestration, so I scheduled the patient on Monday. And Monday, as my routine protocol of doing a pre-operative B-scan, when I do, I see no fluid. I was like, I saw this on Saturday, there was fluid, what happened to it? The left eye, right eye did not have so much constriction, so I waited. But over 3 months, you can see both the eyes are doing well and the fields have restored back to normal. Hence, I want to summarize that when you are looking at things like this, you can always use your B-scan to differentiate a papilledema, pseudopapilledema, or other cause of disc edema. Like, for example, the same patient, when we see, if you do your B-scan, you'll be able to pick up a drusen. This patient had optic disc drusen, which you can confirm by CT scan or an autofluorescence to tell you that, yes, this is drusen only. And in the second patient, where you know this is a frank papilledema because of the history, the presentation, you know this is, but you can definitely confirm by doing the B-scan, looking for the hypoechoic crescent, seeing the size, which is definitely enlarged, and confirm your diagnosis. And finally, a patient like this, who had a sequential vision loss, you see disc edema here. Yes, you would again do your normal B-scan, but here you will not find any fluid because we are looking at both eyes atypical optic neuritis. So where in doubt, you can really go back and use this scan to help you detect a lot of things. And the other thing is, in case of increased ICP, you can in fact pick it up even before the axoplasmic status comes into play and the development of papilledema. And more importantly, in atrophic discs, to detect recurrence of ICP, because these states will not elevate again, but you can definitely see if it's coming back, monitor them, and help it to prevent the resolution of recurrent cases. So thank you very much for a patient listening.
Yes, thank you, Dr. Jyoti. Maybe we will have a discussion after all the session.
Yep.
Because we have very tight time, and the next speaker is Dr. Carmen Chan from Hong Kong. Dr. Carmen will talk about another case of optic neuritis. Please, Dr. Carmen.
Hello, so good afternoon. So first I'd like to thank the organizers for inviting me, and thank you for the kind introduction. I'm going to change the title a little bit to, instead of another case of optic neuritis, I'm going to talk about another case of functional visual loss. So it's a very simple case with 1 or 2 learning points, which I hope you'll be able to take away with you. So I'll try to make it interactive. So just before I start, may I ask how many of you are neuro-ophthalmologists amongst us? Okay, if you're a neuro-ophthalmologist, you are not eligible to answer any of the questions coming up because it will be too easy for you. So, of course, no interest. So I have a 55-year-old female Chinese accountant who was referred from an outside center to our center with both eyes visual loss of unknown cause for a second opinion. So she presented with visual loss in her left eye 3 months earlier with a sudden whiteout and painless, and the same thing happened to her right eye 2 weeks afterwards. So she was of good past health. There was unremarkable family history, social history, or drug history. And on examination at the outside center, both eyes had visual acuity of 660. Ishihara failed color vision, failed test plate. The intraocular pressure was normal, no RAPD, and essentially the ocular examination was normal with no diswelling or pallor. So she was extensively investigated at the outside center. So her MRI brain and orbit with contrast was normal. The OCT macula and the peripapillary RNFL were normal. The NMO, MOG, autoimmune and inflammatory markers were all normal as well. So essentially all the blood work was normal. So at this point, what would you do next? So anyone, those who are eligible to answer this question, please feel free to shout out. It's a very small room. So anything you would do? Anyone? Well, it's conceivable that if a patient with retrobulbar optic neuritis, the peripapillary RNFL and everything else could still be normal, and there's still a chance that you could miss the optic neuritis on an MRI. Even with contrast, there's a 5% chance that you could miss it. So at the outside center, they proceeded to do pattern VEP, which was performed, but the results were lost. Honestly, this was how it happened. So when the patient came to me, it was done, but there were no results. So what would you do next? So, as we say in neuro-ophthalmology, nobody is allowed to go blind without a trial of steroids. So she was given a trial of ONTT steroids with IV methylpred with oral prednisolone, but there was no change whatsoever. So eventually she came to us 3 months later, 3 months after the onset. She came into the room wearing sunglasses with her husband, very nervous. I think the neuro-ophthalmologists among us will know the significance of the sunglasses. Anyone else? No? Well, look it up. Sunglasses sign, published in the Neurology Journal, the Green Journal. So at that time, the visual acuity was 160. She failed the Ishihara test plate. The discs were pink. So I highlighted as pink. And there was no RAPD. This is what her visual field looked like. So at this point, what would you do next? Sorry? OKN. Well, we could do that, but before we do that, I think OKN is actually quite a good a suggestion. But we didn't do that because, for those of you who have listened to my talks before, my favorite favorite thing to do is OCT. So I did the OCT. Okay, so this is what it shows at 3 months. So the OCT is entirely normal. So the RNFL is a 90 something, I can't really see it, but as you know, it's green and green, both eyes. So what am I thinking about at this point? I'm thinking this, well, as you know, if you have an optic neuropathy from, optic neuropathy from any cause, you should have signs of optic atrophy, clinically and also on OCT, usually by 2 months after any optic nerve insult, or maybe I should put any in quotation marks. Okay, so at this point I was thinking, definitely this lady, definitely is functional visual loss. I mean, she looks it, the RNFL has confirmed it. So, but at this point, I did one other clinic examination. It was almost diagnostic there and then. Can anyone tell me what it could be? Sorry? Yes. Why do you say that? Perfect. And in which condition does that happen? I think it can happen in toxic sometimes, and in some of the lesions, some of the optic neuropathies with initial diswelling, that could happen. Well, in fact, in a range of optic neuropathies, this can happen. But I think you're completely right. And another of these conditions is actually Leber's hereditary optic neuropathy. So after I saw this, I actually sent off for mitochondrial analysis, and it came back positive for 14484 mutation. So I'm going to spend a couple of minutes talking about how, so why was this so important to me is because studies have shown that in this case series, which was from Dr. Sadoun's group, this is a very important paper to me because it shows that the OCT in this situation can help to differentiate LHON from other causes in that even before the onset of visual loss, you get ganglion cell thinning in LHON. So for a patient who presents with visual loss at the onset with normal RNFL, so even at that point, if you pick up thinning of the macular ganglion cell layer, it will point you towards further, first it will point you towards that this is not functional, but actually organic, and it will hopefully put you in the right direction for further investigations. So I'm going to spend a few minutes talking about the usual and unusual presentations of LHON. So, we've all learned in textbooks that so Leber's hereditary optic neuropathy presents a bit like optic neuritis in that the onset is rapidly involving central or centrocecal scotoma. Usually it gives you the visual acuity of 660 or less. It's always bilateral. In 25% of the cases is simultaneous. In the others, even if it is unilateral in onset, the fellow eye usually becomes affected in the next 3 to 6 months. The optic disc classically is supposed to look like it has pseudopapilledema, so it's swollen, but if you do the fluorescein, there will be no leakage. However, it can look entirely normal, and I've been fooled a couple of times by that. So the peak onset is the 2nd to 3rd decades of life with a male predominance. So your usual patient is a young boy in their teens or a young male in their 20s. So this is the usual presentation. So males have a 50% of losing their vision if they have the mutation, and females is only 10%. And this is the mechanism behind this is not entirely clear. I was really hoping that, I know that Patrick is at this conference, and I was really hoping that he can elucidate us as to the cause of this. The MRI is typically normal in LHON, but LHON can also have unusual presentations in terms of atypical age and gender, atypical MRI findings, and also we can get L-horn plus syndromes. So unusual presentations, we mentioned that it can happen in 10% of females. So our lady of 55 years old female is very atypical, but it has been reported to present in older adults up to 75 years old. It can also present in younger children. So about 10% or less present in children of less than 12 years old. And in a third, it can be slowly progressive as opposed to subacute onset. It can be insidious or even subclinical, so they could have quite good vision. So if LHON presents in younger children, it is associated with better visual recovery. And the interval between the two eyes, although it is always bilateral, the interval can be can be up to 34 years. So in terms of MRI findings, just now we mentioned that the MRI is usually normal, but there's a case series describing MRI changes in LHON patients. So in this case series of 20 men and 8 women, so in about 2/3 of the patients, they actually had T2 hyperintensity in the posterior portions of both optic nerve and chiasm. And in 16 patients, in 16 patients, there was enlargement of the optic chiasm, but there was no enhancement of the optic nerves or chiasm. And 6 patients had non-specific T2 white matter lesions, which were not typical of MS. So the third aspect I want to talk about is the LHON plus syndromes. So it is usually, although LHON is usually isolated, sometimes it can be associated with, for example, dystonia, myoclonus, and there can be overlap between LHON or an MS, and is labeled as Harding's disease. And there can be a spinal cord syndrome with features of NMO, which can be both seronegative and seropositive. So even if you have seropositive NMO, it can still be associated with LHON, particularly in the patients who are not responsive to steroid treatment. So just before I end, I just wanted to give you a progress of this patient 2 years after onset. So her visual acuity had improved from 160 to 660. And the visual field, as you remember initially, it looked like this. So after 2 years, it started clearing up. So this is typical of 14484 mutation. So I'm going to see her again. This is now 5 years in 2 months' time, and I hope I'll have good news for her and for us. So to take home is that LHON should be considered in anyone, whether older, younger, male or female, with subacute bilateral visual loss, whether it's simultaneous or sequential, and those with poor recovery after steroid treatment. So we need to be aware of MRI findings, the optic nerve and the chiasmal enlargement without enhancement. They can have MRI features consistent with MS or NMO, and always order MRI with and without contrast, unless the contrast is contraindicated. And of course, OCT macular ganglion cell layer thickness can be very helpful for diagnosis of LHON in the acute setting. So thank you.
Thank you, Carmen. Thank you for that fascinating case. Next, we have Dr. Stephen, who is going to talk about impending optic neuropathy.
All right. Good afternoon, everyone. This session is about unforgettable neuro-ophthalmic cases. I don't think this is an unforgettable case, but the lesson is unforgettable. Okay, so this is a 63-year-old gentleman referred from his own eye doctor with a suspicion of arteritic anterior ischemic optic neuropathy. He has some known arterial hypertension, some hypercholesterolemia, and type 2 diabetes. He's been treated for all 3 of them, and he's been screened yearly for his diabetic retinopathy. He just returned from Switzerland a few weeks ago. He travels very often to Switzerland from Denmark for business purposes. He noticed some reading difficulties about 2 weeks ago, and the week before, when occluding his left eye, he noticed very blurred vision on his right eye. He has no symptoms suggestive of giant cell arteritis. On exam, he has a very poor visual acuity on his right eye, where he also has a relative afferent pupillary defect. He has completely normal lab values. So this is how it looks like to start with, and you see here on the right side he has disc edema, on the left side he has a very, very tight disc. This is the OCT, and you see a lot of fluid extending into the macula on the right side. There's a little pseudo hole here on the left side. So the tentative diagnosis is either it's NAION, or it could be neuroretinitis because of all this fluid in the macula. 3 weeks later, he comes at his second visit. At that time, he had had an MRI, which was completely normal. The vision has gone up to 6/12 on the right eye, and the left side is still normal. So this is how it looks like at this time. And this is the OCT, which confirms that the RNFL is increased. On the left side is normal. So these are the visual fields, pretty dense scotoma, most pronounced inferiorly on the right side, and a little on the left side also, but not so much. So the fluid is not that extensive here at 3 weeks. There are some exudates, and so we say that, well, it was probably an iron, and he should come back again in 1 month. He comes back 1 month. At this time, he experiences a gradual visual improvement. He says he just returned from Switzerland another time. And this is how it looks like. Now the RNFL is down to 94 here. And if you look on the left side and remember how it was, of course the visual fields are pretty much the same, but if you look on the left side, this is the interesting part here. He has no problems on the left side, but actually there is a little fluid now extending into the macula on the left side. And also the RNFL has gone up from 90 something, 94 I believe it was, to 106 on his asymptomatic fellow eye. Okay, so he comes back on the 4th visit. It's 3 months now, and he experiences visual worsening, especially when reading, and he experiences blurred on the left side. On the visual acuity is good here. He just came back from Switzerland once more, and he's been flying. He says he's been flying to Switzerland 6 or 7 times for the past 6 months. So this is how it looks like now. Of course, there's now atrophy on the right side, and on the left side, there's clearly disc edema and RNFL swelling. So he has a left AION with a central scotoma here on the left side. Here you see there's much more fluid extending into the macula also on the left side. So he has a left iron as well. And on the 5th visit, the vision is now stable, he's healthy, he hasn't been flying, and now he's starting to getting some atrophy on the left side as well. All right, so if we plot the RNFL thickness of the second eye over time. So we saw him, this was his 2nd visit, 3rd visit, 4th visit, 5th visit, and final visit. And here are the RNFL on the y-axis. And of course, when he had his NION on the left eye, he had a steep increase in RNFL. But what is the teaching point here is that actually he had an RNFL increase also between the 2nd visit and the 3rd visit, asymptomatic. So this is a case of a bilateral sequential NION in a middle-aged frequent flying man, each event occurring after flying. And this asymptomatic RNFL increase on the second eye after flying, he had before the second event occurred. So this is actually a thing, the flight-induced NION, or as I like to call it, fly-on. I've actually gone back and looked at the few cases we've had, and some of them we've actually seen just as a regular follow-up on the first eye, and it's very, very typical that there is this incipient RNFL increase on the fellow eye just before getting the proper NION. So what could be the explanation for this? Well, flying actually affects your blood oxygen saturation levels due to the reduced air pressure and lower oxygen availability in airplane cabins. And commercial aircraft cabins, they are usually pressurized, simulating altitudes of about 1,800 to 2,400 meters. But at these altitudes, the partial pressure of oxygen is lower than at sea level, which can lead to a decrease in the oxygen saturation. For most people, this is no problem. We see in all people saturation goes down to about 93 or 94%, but it can be a problem if you have a very, very tight disc to start with. There is one study which is actually quite nice, where they studied the pressure within airplane cabins. And what was interesting in this study was that actually the wider airplanes or the newer models, they have a lower cabin pressure than the narrow airplanes. So actually it's contradictory to what most people think. It can be better flying long distance than short distance, because in short distance it's the narrow airplanes. The least likely clinical explanation, which has also been introduced, was that if this was due to a thromboembolic event. The problem with this explanation is if you should suspect a deep vein thrombosis to embolize, then the thrombus must pass through a right-to-left shunt, such as a persistent foramen ovale, to enter the arterial circulation, and this is pretty unlikely. An interesting theory, now it's the second time we hear about it, Professor Sadun today, it's because at Harvard they've done some studies on mice at different oxygen levels, and they find some very significant changes in the metabolism and the mitochondrial function at these higher altitudes. And based on that, Professor Sadun has come up with this theory that when the ATP production goes down, the retinal ganglion cell axons compensate by upregulating their mitochondria, and this in turn constipates the axons. So perhaps the appearance of the RNFL swelling in the pre-symptomatic stage of LHON can actually be a trigger for the event to happen. This is in LHON, but this could also be taking place in NION. So the swollen axons, more than the ischemic ones, might trigger the AION. So take-home message from this is you can fly on because there are millions of people flying all the time. Shouldn't be afraid of flying, but it could be possible that the lowering of the blood oxygen saturation in a susceptible individual with a tight disc with a very low cup-to-disc ratio, with an incipient NION, with an RNFL increase, which is asymptomatic, plus or minus vascular coexisting conditions. This could be a trigger for hypoxemia and pose a risk of NION. So if someone has a history of a unilateral NION coupled with other underlying vascular insufficiencies and a disc at risk, it might be wise to wait flying until there's no more disc edema. Usually I say 2 months. So beware of the second eye and look for asymptomatic RNFL increase. The question, should we have a possibility of supplemental oxygen? This is always a matter of discussion. I know that it has been possible for some patients to request it on some flights, but that really depends on the airline. All right, so fly on, or I want to say fly on. Thank you.
Thank you, Professor Stephen Hammond. And the next speaker is Dr. Virender Sachdeva from India, and Dr. Sachdeva will talk about how to track a snowman. Please.
Good afternoon once again, everyone. And I would like to thank APAO Scientific Committee, Dr. Carmen Chen and Dr. Rashmin for inviting me to present this interesting case. So let's begin with the case. This is the story of a 52-year-old male. 52-year-old male who presented to us with complaints of gradual painless decrease in vision in both eyes, right eye more than the left eye for 1 year duration. There was no other significant ocular history. Similarly, there was no other significant neurological complaints. However, he was hypertensive and he also had hypercholesterolemia, for which he was on treatment for 2 years. The chief salient examination findings of the patient showed that the visual acuity in right eye was only hand motion, and in the left eye it was 20/80. There was a grade 3 RAPD in the right eye, whereas the rest of anterior segment was unremarkable. Coming to the fundus examination, what we see here is that the media is clear. We see the pretty large area of the fundus photographs over there. We can easily make out that there is optic disc pallor in both eyes. At the same time, what else you can see? So if you look over here in the right eye, we can make out that there is a small patch of RP mottling there with areas of hyperpigmentation in the right eye along the infratemporal arcade. But if we see carefully, we can also make out that there are, I think the mouse is not working. Yeah, there are certain areas at the macular area also we can make out that there is presence of the RPE changes. And if you see more carefully, you can see that there is an area of depigmentation running down vertically in the right eye as well as in the left eye. So what investigation you would like to get next? Let's confirm the findings. So you have something like autofluorescence. You can make out that there is a definite area of hypoautofluorescence corresponding to the area of RP mottling. We see a large track-like thing in both eyes running down vertically. So what triggers in our mind? Could be a chronic CSCR. We see such a picture there. And can the optic atrophy be secondary to it? No. Well, steroid. Let's see. So we did obtain a OCT. We did find a pachychoroid spectrum. At this point of time, the patient was diagnosed to have optic atrophy and chronic CSCR and was referred to Neuro Ophthalmologic. So let's recap something. We know about conjunctive optic atrophy. We know that it is in association with diffuse retinal changes. There is a widespread damage to the ganglion cells that does cause optic atrophy. We can see a temporal pallor. Like in this patient, you can see that there is a area of RPE loss here and multiple chorioretinal atrophic patches. It is commonly seen with retinal degenerations where widespread damage is happening. Can also be a part of neurometabolic disorders, lysosomal storage disorders, mucolipidosis, and metachromatic leukodystrophy. But many of them have an onset much earlier in life, and they might have other systemic findings. Our patient did not have any of these. So possibly the retina colleagues were correct in thinking that there is something beyond it. We went back and also tried to analyze. There was asymmetric vision loss, while the retinal findings are also quite similar. The disc pallor was more in the right eye, and there was marked vision loss in the right eye. So given this, we went ahead and did the visual fields of the patient. And then this is the field of the left eye. We can see that on the total deviation plot, we see an advanced field effect. But if we look at the grayscale, we can see that there is a spec for the vertical. It's a temporal hemianopic scotoma in the left eye. The right eye fields were not possible. So we assume in presence of optic atrophy, it's like a complete field effect. So if we were to analyze it, the closest analogy will be a junctional scotoma, wherein we have an advanced field effect in one eye and the temporal hemianopic field effect in the other eye. We label our patient to be having a presumed junctional scotoma because we cannot verify the right field effect. And if we use a similar analogy, the lesion should be at the junction of the anterior portion of the chiasm and the proximal optic nerve. So what do you want next? MRI. So MRI of the brain and the sella. So that's where it is. We have a large, these are the axial scans show a large oval mass lesion which is occupying the sellar area. We can identify best it in the middle image, which is the T1 post contrast coronal image. We can see a large mass lesion over there which is occupying the entire area of the sella and the suprasellar area. The pituitary gland cannot be identified separately, so suggesting that it should be more likely to be a pituitary macroadenoma. And you see that on the post contrast it is homogeneously enhancing. What also you see inside is that the central portion is appearing to be relatively less bright. It's like a snowman. So that's why tracking a snowman. And you can see that the chiasm cannot be picked up. It is totally flattened. So this possibly explains why everything could have been happening in our patient. We have a optic atrophy in our patient, chronic CSCR, and a pituitary macroadenoma. So obviously we refer to the neurosurgeon for planning the surgical resection. But are they related? Could there be a correlation? We sent the patient with the message that please check serum cortisol levels, actually all pituitary hormone levels, prior to doing the surgery. Why this? We'll come back to this by seeing another similar case. Very similar case seen by my colleague in another campus, Dr. Vivek in our Bhubaneswar campus. So this was a 51-year-old gentleman, seen by him complaining of decrease in vision in right eye from 2 years. The patient had a prior history of CSCR in the right eye 2 years prior, for which focal laser had been done. The past medical history was suggestive of diabetes and hypertension, which was uncontrolled. The vision loss is not much marked. We see 20/30 N12 in right eye, and left eye is 20/20 N6. There is no RAPD, but we see a temporal pallor, again right eye worse than the left eye, and these are the visual fields, classical bitemporal hemianopia. So this patient again showed a very similar large pituitary macroadenoma, and the pituitary endocrine level showed increased levels of serum cortisol as well as prolactin. So this was possibly a large secretory pituitary macroadenoma that was actually causing the chiasmal compression and could have caused the CSCR as well. And we had one more clue: the patient's hypertension was uncontrolled. So possibly correlating everything, that's why we sent our patient with these requests. So this is to summarize what the patients can have: bilateral optic atrophy, cellular type field defect, as well as chronic CSCR, and the cortisol secreting adenoma could be the common cause. So we do hear about the CSCR, which is caused due to the steroid intake, right? So chronic steroid usage can lead to. How is it different? We know that CSCR affects the men more frequently than the women, but there is a lesser male predilection. It can occur in women as well. It is usually bilateral, can have an atypical presentation, can be chronic, and can have bullous variant with very high elevations. So if you see these pictures, do try to check up for the serum cortisol levels for the patients. We went back and tried to search the literature. This was the most relevant report that we could find, wherein it was reported in IOVS. A 42-year-old female had chronic CSCR, which was not improving over a period of 6 months. So the patient was evaluated, and the serum cortisol levels were found to be elevated. And then the physician did the imaging, wherein the patient was found to have a pituitary macroadenoma, which was secretory. Post-surgery, everything restored for the patient. So this is the correlation that I wanted to highlight, that how a chronic CSCR optic atrophy could be related to a secretory adenoma. So this is the follow-up of our patient 2 months post-operatively. The patient did not recover vision in right eye. In fact, whatever residual vision was there was lost, but left eye improved to 20/20. Right eye had grade 3 RAPD. This is the field showing few preserved areas in the right eye, where we can see that in the perimacular area you have good sensitivity, possibly from where he was seeing. And these are the follow-up OCTs of the patient. Just as a paradox, despite us telling the neurosurgeon to get the serum cortisol levels, it was not done because of the insurance issues. It was done as a charity patient, so that's why they did not afford it. But the other case was very similar to it. So the take-home message is that in patients with chronic or recurrent CSCR, we should check for the serum cortisol levels, look for the Cushingoid features that might be there. Steroid-induced CSCR can have specific features like bilaterality, poor response to treatment, and bullous variants can be seen. They can have a chronic course. And when an optic atrophy exists with CSCR, do not just assume it to be secondary to the CSCR, but do a visual fields at least, and if you have a corresponding cellular kind of field defect, better to obtain an imaging and rule out a secretory adenoma. Thank you very much.
Thank you very much, Miranda. We move on with masquerade optic neuropathy by Dr. Eri Nakano.
Good afternoon, everyone. I'm very pleased to have this opportunity to speak to you today. I would like to present a challenging case from our Japanese hospital. I encourage everyone to think through the diagnostic process as if you are evaluating this patient yourself. Now let's move on. The patient was a 61-year-old male who presented with a chief complaint of a gradually progressive hazy vision in the left eye for approximately 2 months before visiting our hospital. His past medical history included bilateral sinusitis, for which he had underwent surgery around the age of 30. He quitted smoking at the age of 45, and although he drank alcohol daily, his intake was not excessive. He had no dietary imbalances. His only regular medication was an anti-allergic drug. Regarding family history of ocular diseases, his paternal uncle had glaucoma, but there was no other family history of visual impairment. Best corrected visual acuity was 20/20 in the right eye, but decreased to 16/20 in the left eye. Intraocular pressure was within the normal range bilaterally. The critical flicker fusion frequency, CFF, was 39.2 Hz in the right eye and 30.2 Hz in the left eye. The left eye showed a positive RAPD. No significant findings were observed in the anterior segment or media. Fundus photography at the initial visit showed no abnormalities. OCT did not reveal any thinning of specific retinal layers or disruption of the outer retinal structure. The optic disc showed no swelling or atrophy, and there was no thinning of the inner retinal layer in the macular region. However, despite these normal fundus findings, the left eye had severe visual field defects. Humphrey Field Analyzer, Humphrey 30-2, showed a mean deviation of minus 23.74 decibel with a decreased foveal threshold of 26 decibel. Goldman perimetry demonstrated generalized depression of visual sensitivity in the left eye, with both central and paracentral scotomas. The right eye's visual field was normal. Given the patient's symptoms, unilateral visual dysfunction in the left eye with a positive RAPD but no intraocular abnormalities, the suspected region is likely located between the optic nerve and the optic chiasm. What possible etiologies should be considered in the case? In the differential diagnosis of optic nerve diseases, the time course of visual dysfunction is a crucial factor. The time course varies depending on whether the underlying cause is ischemic, inflammatory, or compressive. The red line represents ischemic optic neuropathy, which has a sudden onset and follows an acute course. Vision loss occurs rapidly at the time of onset, and in most cases, visual function remains stable thereafter. The blue line indicates optic neuritis, which follows an acute to subacute course. Vision typically worsens over a few days to a maximum of about 2 weeks. In cases of idiopathic optic neuritis, spontaneous recovery usually follows. The green line describes compressive optic neuropathy, which follows a chronic course progressing over months or even years. Because of its slow progression, it is often challenging to distinguish from glaucomatous optic neuropathy. In this case, the patient's visual impairment gradually progressed over approximately 2 months, making compressive optic neuropathy the most likely diagnosis. The absence of retinal inner layer thinning in the macular region suggests that compression is occurring behind the optic nerve without causing retrograde degeneration in the retina yet. If the cause were ischemia or inflammation, it would be highly unusual for the optic nerve to remain unchanged 2 months after the onset, as Carmen Chan said. Therefore, we performed contrast-enhanced orbital MRI. However, an unexpected result awaited us. Surprisingly, no compressive region was found anywhere. Additionally, there were no sinus regions that could be suspected of contributing to the visual dysfunction, nor was there any enhancement of the optic nerve itself. We had to re-evaluate our diagnosis. RAPD can occur not only in optic nerve diseases, but also due to extensive retinal disorders, such as central retinal artery occlusion or acute idiopathic blind spot enlargement syndrome, AIOS, including azure. If there was no abnormality in the optic nerve, the only possible explanation for the positive RAPD was retinal dysfunction. even though there were no OCT abnormalities. We therefore firstly asked the patient whether he had photophobia and night blindness, as these are suggestive of retinal damage. It turned out that both had appeared right around the time when the patient started to notice a loss of vision. However, no significant findings were observed on autofluorescence fundus photography, fluorescein angiography, or berries. It was only after performing a full-field ERG that we were able to identify highly characteristic findings. Can you tell? We see a decreased rod response in the left eye and a negative ERG in the combined cone rod response, where the B wave is lower than the A wave. In the cone response, there is a square A wave with a flattening of the last part of the A wave. These suggest on-type bipolar cell damage. This selective impairment of on-type bipolar cells is characteristic of melanoma-associated retinopathy, MAR. Let's review MAR. MAR is a subtype of autoimmune retinopathy, AIR. AIR is broadly classified into paraneoplastic AIR and non-paraneoplastic AIR. Within the paraneoplastic AIR category, there are MAR and cancer-associated retinopathy, CAR. MAR is a retinopathy caused by malignant melanoma, typically with metastasis, and is an extremely rare disease. The average age of onset is 57.5 years, with a slight male predominance. The main symptoms are progressive visual dysfunction accompanied by flickering or pulsating photophobia and night blindness. It is usually bilateral, although rare cases of unilateral involvement have been reported. It is often associated with a history of malignant melanoma, and the average time interval between tumor detection and the definitive diagnosis of MAR is 3.6 years. However, the interval varies widely, with reported cases ranging from as early as 2 months to as late as 19 years after melanoma detection. And importantly, in some cases, MAR may even precede the diagnosis of malignant melanoma, so careful attention is required. Fundoscopic examination may reveal optic disc failure, retinal vessel narrowing, mild retinal vasculitis, retinal pigment epithelium abnormalities, and vitreous cells. However, approximately half of the cases show no detectable abnormalities. ERG findings can vary widely, but since bipolar cells are often primarily affected, their dysfunction is reflected in characteristic findings. Like our case, a decreased rod response, a negative ERG, and a square A wave strongly suggest MAR. Additionally, in recent years, it has been found that MAR is caused by the production of antibodies targeting retinal proteins, particularly those that react with the cation channel TRPM1, which is produced in melanocytes and on bipolar cells. Our case involves a 61-year-old man whose main symptoms and ERG findings are consistent with MAR. Therefore, the diagnosis is MAR, meaning that somewhere in this man's body, a malignant melanoma must be hiding. We need to find it as soon as possible. However, no tumor was found. A thorough dermatological examination for melanoma was conducted, including a biopsy of a pigmented nodule on the lower jaw, which was diagnosed as a pigmented nevus. Considering the possibility of a primary nasal melanoma, nasal endoscopy was performed, but no significant abnormalities were detected. A liver mass was identified on whole body CT, but further evaluation with abdominal ultrasound and MRI suggested it was a hemangioma. No other tumors were detected. In addition, anti-TRPM1 antibodies tested negative. Therefore, his final diagnosis was NPAIR so far. How should it be treated? There is no established standard treatment for autoimmune retinopathy. In paraneoplastic cases, treating the underlying tumor is the highest priority. Additionally, systemic and local corticosteroid therapy, immunosuppressants, IVIG, and plasma exchange have been used empirically. In this case, we chose STTA as the local ocular treatment. 1 month after STTA treatment, the visual acuity in the REST-Y improved from 1420 to 2020, and the CFF increased from 28.3 Hz to 47.2 Hz. Improvements were also observed in the MD value of Humphrey 10-2 and the foveal threshold. A second STTA was administered 3 months later, and the patient has remained relapse-free for 6 months since the initiation of treatment. Additionally, a full-field ERG performed at the 6-month follow-up showed remarkable improvement. Here is a summary of lessons learned from this case. RAPD can occur even in retinal disorders. ERG may detect abnormalities even when OCT shows no significant findings. Remember the characteristic ERG findings of MAR. Prompt tumor screening is the top priority, but adjunctive local treatment can be effective. Since retinopathy can precede tumor detection, continuous follow-up is essential. This is the most important point. Thank you for your listening.
Thank you, Dr. Eri. The last talk for the session is by Dr. Sudha. She's going to talk on another case of IIH. After that, we'll have discussion on all the topics so far.
Thank you to the organizers for giving me an opportunity to present today. I will be sharing with you a patient with idiopathic intracranial hypertension. I have no conflicts of interest to declare. I would like to acknowledge Professor Chen and Dr. Pratyush Giri, who were both also involved in the management of this patient. So a 54-year-old Caucasian lady presented with symptoms of gradual onset of blurred vision, progressing to tunnel vision. She also had symptoms of persistent headaches and diplopia. She had symptoms of pulsatile tinnitus and transient obscuration of vision. She reported that she had lost 20 kilograms of intentional weight loss, which she had achieved through diet and exercise prior to the onset of these symptoms. Her past medical history was unremarkable. She was on Duramine for weight loss, and she denied history of intake of any medications, including tetracyclines, oral corticosteroids, lithium, or vitamin A. Sorry, I think it is going, my slides are progressing without the mouse click. Sorry. I think it's just progressing. Okay, I'll just continue. Okay. What's that? Yeah, okay. So on a presentation, she was noted to be obese. Anterior segment examination and cranial nerve examinations were within normal limits. The neurological examination was normal. Fundus examination was suggestive of papilledema with evidence of grade 2 frisson grading in right eye and grade 1 in the left eye. OCT nerve fiber layer demonstrates optic disc swelling, which is worse in the right eye compared to the left eye. She underwent a Humphrey visual field, and as you can see, there was no evidence of enlarged blind spot or peripheral field constriction. Possibly there's some nasal step on the left eye. She had MRI of her brain, which did not show any space-occupying lesion or demyelinating lesions. However, there was distension of the perioptic subarachnoid space, posterior flattening of the globe. She had partial empty cellar and also CSF distension of the Meckel's cave. She underwent CT venogram, which did not show any dural venous sinus thrombosis. She underwent lumbar puncture, and this demonstrated an opening pressure of 40 centimeters of water, and the CSF analysis was within normal limits. So she was diagnosed as idiopathic intracranial hypertension based on the fact that she had papilledema, normal neurological examination, MRI findings with no space-occupying lesion, and CTV showing no dural venous sinus thrombosis, normal CSF examination, and an opening pressure of 40 centimeters of water. So she was started on acetazolamide, 250 milligram 3 times a day, which was progressively increased, and she was advised weight loss. 3 months later, she presented to our unit, and at this time, she still had persistent headache. There was no evidence of tinnitus or transient obscuration of vision, and there was the disc swelling itself was settling down. So here's the OCT. You can see that the disc swelling is settling down, and comparatively, this is the baseline OCT. So while these features are typical of idiopathic intracranial hypertension, there are a few atypical features in this presentation. So first of all, the age. The patient is not in the normal demographic of the patients presenting with idiopathic intracranial hypertension. As we know that the patients who are, it can happen in patients with older age, but they tend to less likely have symptoms of headache, and they're usually not obese. And secondly, as the patient reported, she had preceding weight loss at presentation. I think my thing is just going on. Okay. So she had the hematological, so we ruled out basically the secondary causes of idiopathic intracranial hypertension, and there was no evidence of anemia or polycythemia. CTV was already performed. She denied history of systemic diseases, including chronic airway disease or obstructive sleep apnea. Renal functions, thyroid functions, and parathyroid levels were all within normal limits. We re-evaluated the medications, and there was no suggestion of secondary idiopathic intracranial hypertension with the medications. So the same treatment was continued. She was advised weight loss. Oral acetazolamide was continued. 6 months after the initial presentation, she presented with severe headache, tinnitus, recurrence of papilledema of grade 2 to 3, and she had bilateral 6-nerve palsy, varices. And she had self-seized her Diamox due to the typical side effects that most patients have. Any suggestion from all of you as to what I should do now? I think my slide gave away. Okay, I'll continue. So we went on to take further history from the patient, and she described having cutaneous lesions in her lower legs and the right hand. Now, these lesions that she had were annular scaly lesions. So biopsy was performed from these lesions, and they showed evidence of atypical lymphocytic infiltration of the dermis and the epidermis. While I do not have picture from the patient, but this is a typical presentation of patients who present with mycosis fungoides. So this is what, this is a much later case. Our patient, it was not so significant. She had just annular scaly lesions. So at this time, she was reviewed by the hematologist. Peripheral blood smear was performed, and this showed evidence of leukocytosis with lymphocytosis. So she underwent flow cytometry, and the immunophenotyping was suggestive that the B lymphocytes were normal, and there was no evidence of B cell monoclonality. She basically had T cell lymphocytosis, and these were suggestive of, there was an increased population of CD3 and CD4 cells, but the CD8 was within normal limits. And the CD3 and CD4 cells were positive for VB16 marker, and this clinched the diagnosis of cutaneous T cell lymphoma. So she had repeat lumbar punctures over the next 6 months, opening pressures 27 and 25 centimeters of water. Biochemistry showed mature lymphocytes, probably in the higher limits of normal, but still within the normal limits. Protein and glucose was normal, and unfortunately, she did not have CSF samples which were sufficient for flow cytometry. She underwent PET scanning, and there was no focally avid lesions involving the lymph nodes or the bone marrow or any other organs, but she has some cutaneous lesions as is seen in the right hand and also in her legs. So further investigations, showed that she had persisting leukocytosis and abnormal lymphocytes. CT, chest, neck, abdomen, and pelvis showed no pathological lymphadenopathy or no other organ involvement. She underwent repeat MRI of the head and spine, and there were no intracranial lesions or evidence of CNS lymphoma. So here we have a 54-year-old patient who is obese, raised intracranial hypertension, normal CSF examination, and radiological features suggestive of idiopathic intracranial hypertension, but she also has an associated diagnosis of cutaneous T-cell lymphoma with no CNS involvement. So cutaneous T-cell lymphoma is a rare hematological malignancy that typically presents with cutaneous lesions. The CTCL can have a wide range of outcomes, from indolent and favorable outcome as seen in mycosis fungoides, or rarely it can be a more aggressive and morbid outcome as can be seen in Sézary syndrome. Visceral metastasis is uncommon, but it can occur, and CNS involvement is typically rare. What is usually seen is that these patients actually have large cell changes, and then they can go on to have visceral metastasis before CNS involvement occurs. Now, CNS metastasis in CTCL has poor prognosis, and the patients require treatment with radiation, surgery, and high-dose methotrexate. So the probable diagnosis in this patient is paraneoplastic syndrome associated with cutaneous T-cell lymphoma. The possible etiology here is increased white cell count, which has resulted in increased resistance to the flow of CSF from arachnoid villi into the sinuses, resulting in increased intracranial pressure or papilledema. CNS lymphoma is unlikely because imaging studies were normal and neuroimaging was also normal, and CSF fluid did not show any abnormal lymphocytes, and papilledema resolved after the initial lumbar puncture. Now, paraneoplastic syndromes are immune-mediated response, and they can present with paraneoplastic antibodies or CSF lymphocytic pleocytosis, high IgG index, and oligoclonal bands. Pseudotumor cerebri or secondary idiopathic intracranial hypertension has been reported in patients with chronic myeloid leukemia, acute myeloid leukemia, and acute lymphocytic leukemia, and also acute promyelocytic leukemia. And the pathogenesis is somewhat similar to what I have just described with the increased white cell count, or it could be from CNS infiltration. However, in leukemia, there's also a risk of disseminated intravascular coagulation, which can result in dural venous sinus thrombosis. Now, the patient was subsequently managed with Diamox, topiramate, and she also underwent a VP shunt to relieve her symptoms of headache. With regard to the cutaneous T-cell lymphoma, she was managed by her treating hematologist. So the lessons that I learned from this patient is that it's important to examine the patient as a whole rather than just do an eye examination as an ophthalmologist. It's always important to consider secondary causes of idiopathic intracranial hypertension in patients presenting with atypical presentation, including older age, males, or normal BMI, also patients who may present with cranial nerve other than sixth nerve palsy, or they may have additional neurological features. Fortunately, this patient had a good outcome. However, CNS lymphoma has a poor prognosis, and early diagnosis is critical. So I'll leave it for you all to decide whether secondary idiopathic intracranial hypertension or pseudotumor cerebri is a better term, because here we have an etiology, but the pathogenesis is not known. Thank you, and sorry the slides kept going on.
Thank you so much, Dr. Sudha. We have a little more than 15 minutes. So any questions from the audience to any of the speakers, or any comments, suggestions? We have a mic there.
Get the speakers up here.
Sure.
Could the speakers come up here and have a seat?
I wanted to ask Dr. Jyoti ma'am, in one of her case, she demonstrated that when neurosurgeon did LP, then edema went down. So do you suggest if facilities of optic nerve fenestration not there, then can LP be done? Or routinely do you find doing LP reduces edema?
Yeah, so for detecting papilledema, once you have detected and you want to find out the cause, you need to rule out primary or secondary causes. So when it's a primary cause, we're looking at an idiopathic intracranial hypertension. Now to confirm that, an LP has to be done to look for the opening pressure. So that's the reason why they would anyway do it. So usually they do not take out so much fluid. It's just for a diagnosis and sometimes they collect it. If you take too much of fluid out, you'll land up with hypotension that can happen, as a result of which it doesn't happen. So in this case, incidentally it happens. Sometimes in certain cases, like in children, they have these serial LPs done to try to take out fluid little by little. But that's not the only thing. And in certain cases, so it depends on what is the patient presenting with. If it's an issue of vision, then yes, in that case, we may not be able to get that much effect, because by the time you take out the fluid, to get an effect at the optic nerve head is not always conclusive. In which case, optic nerve sheath fenestration becomes a better option, because we have kept it only for cases where the vision is threatened or the visual field is threatened. In cases where the patient would present with headache or something, then we are not looking at an optic nerve sheath fenestration. We are looking at something like a VP shunt or an LP shunt to treat the problem. But for diagnosis, they anyway do LP, and they do it only in an amount that is enough to be diagnostic, and they're more than therapeutic.
Okay, thank you.
I have a question also for you.
Yeah.
Did you correlate? Did you correlate the thickness of the nerve sheath behind the globe with the Friesen grade?
So I have not really done that. My technique of using the B-scan is only to confirm that there is papilledema, to watch over time, and then when you start treating the patient, so sometimes the discs start flattening, but you're not really sure. So when the neurologist asks me, do I stop the medications, I look at the B-scan. If the B-scan shows me it's totally flat, but the discs have not yet flattened, I can give them a go. Yes, you can go ahead and slowly taper. So I look at it only to diagnostically decide whether I have to stop the treatment or not. Or in patients where there is already atrophy, but patient has come back with headache, they want to reconfirm if the fluid is coming back. Yes, there are a lot of studies which actually measure, and you can, but I'm just looking at more the reason to find out whether there is fluid, whether it should continue or discontinue.
Okay, thanks. The reason why I'm asking is because in clinical practice, it's very hard to distinguish grade 1 papilledema from pseudo papilledema. So my suspicion is that it will be very hard to measure a significant increase in the nerve sheath diameter in the subtle papilledema, grade 1 papilledema. So I think it would be nice to kind of make this.
Yeah, so here I would like to make a point. So if it is a pseudo-disc edema, you will find significant hypoechoic crescent. So I'm not looking at the size. And usually if you take a measure, anything more than 4 millimeters definitely indicates that there is. But I'm not just looking at the size of the disc. If I see the crescent, and this is the one picture, it's a one time, but when you're doing the scan, you're doing it dynamically. So you actually see the crescent coming, going. So you know, in a normal individual, we have done in about 100 patients, we do not see fluid at all. So when you see the fluid, you know definitely that there is papilledema, and it's not a pseudo-papilledema.
Since Jyoti, you are on the spot, just one question for you. That how easy it is to pick up these findings? Do you require a technician who needs a training, or an ophthalmologist who needs a special training to?
No, not at all. As I said, exactly. In fact, my video is also available on YouTube. If you do this, it just takes you a few seconds to follow it. All you need to do is direct your probe correctly, and you just do it in few seconds. You'll see the fluid is there or not. And I had recently a patient last week who was on treatment, had discontinued Diamox. She was fine, and the discs were still same, no situation. But previously nobody had done the B scan, and she had already stopped and tapered Diamox because her symptoms still persist. And when I saw it, I found a disc which is significantly thick, and there was more than 6 millimeters. But clinically she was looking the same, so they thought maybe she's resolving, so they did not. But the technique is very simple, and you do it, takes just a couple of seconds to do it. And it's something which we can do. We cannot keep doing serial LPs or serial MRIs. But this will tell you whether we should continue or not.
Thank you, Jyoti. Yeah, Sangeeta.
Hello. I met some of you, it seems, on our way from Nanos to here. But we've had this is for Dr. Sudha. We had a very similar case presented at Walsh. It was a case of mine who had all the signs of IIH radiologically, and a BMI of 30, but ultimately ended up being diagnosed with T-cell lymphoma and had a double positive cell on the flow cyto. But there were no, and the white cell was not increased or very nominally increased. And you mentioned it was hard to understand what was the mechanism. And of course, the presumption was that there was arachnoid blockade by the abnormal cells, but we didn't pick up too many cells. So what I didn't understand the speculation.
So basically what I'm saying is that there's just increased blood viscosity, reducing the outflow.
But there's no peripheral leukocytosis.
There's leukocytosis involving the blood, but
there
not
was, you measured
yes, which I did show. Yes, she did have some leukocytosis.
Because our patient did not have that. And then what was the reason for a VP shunt? I didn't understand
Actually, because her headache didn't come down, so she had acetazolamide, and basically with hers, because she was mycosis fungoides, there is no treatment from the hematology point of view. So she is being managed, just being observed at the moment, because it is very, very early stages, and she doesn't need any hematological involvement. So what she's having is, she is having her, she had acetazolamide, and she was encouraged weight loss. She wasn't actually tolerating the acetazolamide very well. So she underwent VP shunt, basically to reduce the intracranial hypertension.
Okay, great. No, thank you, because the edema itself wasn't an indication. And
yeah.
All right, thank you.
Yeah. Thank you, sir. Yes.
The question is for Dr. Sudha only. I also wanted what was the rationale for VP shunt when there was no progressive issue.
It's just for headache, just headache, not settling down, not from our ophthalmic point of view.
Yeah, that's what I just.
Any other comments or questions? Yeah, of course.
That is Dr. Nakano. Nakano. Yes. About the, because in your case, it's unilateral, and we have presumed that this is non-paraneoplastic AIR. What was, did we have a recurrent antibody? Anti-recurrent? Yes. It was positive?
It was positive, yes.
Okay. So that makes sense, because otherwise, and I was also not familiar with the flicker, flicker frequency. Can you tell us more about what that is? Because in your initial, what does that use? Just to educate me, what is that used for? I'll let you speak.
CFF is relatively popular in Japanese ophthalmologists, and we examine it when we suspect the optic neuritis disorders. So patients with RAPD, and if the figure decreases, then we suspect the optic nerve disorder. So for the first time, I suspected the optic nerve disorder, particularly compressive optic neuropathy. However, this patient has the different diagnosis.
So is it like
Yes.
Does it have any similarity to the contrast sensitivity?
Is it a functional test?
Something like that, similar to that?
Basically, this is a functional test, and so critical flicker test, which means multisynaptic delay. So if the patient has optic nerve diseases, that means synaptic delay is more marked, and therefore it's more like a RAPD test. But kind of, as far as I'm concerned, I'm not relying on that CFF test. But so far, the Japanese neuro-ophthalmologists prefer doing that CFF because of the number counts. So you can quantitatively evaluate the patient's status. So as far as multiple synaptic delay is concerned, such as like optic neuropathy, CFF delays. And if the macular disease or retinopathy, basically
distinguish a compressive from an inflammatory cause with this, what you are using?
As a rock CFA?
Yes.
I don't believe it.
Thank you.
Any other questions? Yeah, please go ahead. We have a couple of more minutes.
So I wanted to ask Dr. Jyoti ma'am, what's your algorithm about management of disc edema with medical like Diamox or neurosurgical intervention, and like when you decide to intervene with your fenestration procedures, for which cases you feel you have an edge over medical or neurosurgical intervention?
So unless you've proven vision loss, which is significant vision less than, I mean your vision is gone and fields are unable to do, or fields are less than 10 degree, and patient cannot be taken in for, and he's on maximal treatment, in those cases I can go ahead and do ONSD first, and then any surgery required like a VP shunt and all will be done as a second procedures. I've also done simultaneously VP shunt and ONSF in the neurosurgical OT at the same time. But it all depends on how the patient presents. So many a time the patient has, like if you saw, I showed a case where there's unilateral ONSF. In that case, what has happened is the left eye had constricted visual fields. Right eye had around 20-degree field. So I don't have to touch the right eye. Because you should understand, I am trying to relieve only the fluid from the optic nerve. The problem is not yet treated, for which the neurologist has to continue. So in case the treatment doesn't happen and you want another attempt, you have the other nerve to do. So in that case, only because of significant visual field loss, which is less than 10 degree, or the vision threatened in the primary, I mean the central vision, in those cases I go ahead for an ONSF. Otherwise, it just goes back to the neurologist to treat. Usually I have a direct collaboration with my neurologist. I will tell them there is fluid, I feel this is a vision issue, go ahead. So they can sometimes do. In case I decide to go ahead with a neurosurgery technique like a VP shunt or an LP shunt, I give about 3 to 4 weeks time, during which I monitor 2 weekly the visual fields. I feel it's improving, then I wait and I'll watch. Anytime I feel the vision is threatening, I can go ahead. There are times when patients come with cerebral venous thrombosis, they have good vision, suddenly in 2 weeks they come with vision loss. Those I will take it as an emergency to take off the fluid first and then send them back to the neurologist. So each case is individualized, but only when you have a field loss or a vision loss, you go ahead and do an ONS.
They were all fascinating cases, so thank you so much all the speakers. Thank you APAO and AIOS for this opportunity, and I thank the audience for their active participation. Thank you.